Everyone, we're glad you could join us for this webinar and presentation on the treatment of epilepsy during emergency situations. So my name is Dr. Welty, and I am going to be the moderator for this session from the International League Against Epilepsy. So we're going to be talking today about the management and treatment of seizures and epilepsy during emergency situations. This is a presentation in an educational program by the International League Against Epilepsy Emergency Task Force and is directed towards individuals who may be dealing with individuals who are caught in a crisis, emergency, disaster type of situation. The International League Against Epilepsy has a crisis response website with a number of resources that are available to anyone. And you can take a picture or click on this QR code and it will take you to the crisis response website, and you can download or look at the information that is available on that website. In relationship to our presenters today, there are no conflicts of interest related to the topics that we will be discussing. So our objectives for this, for everyone who's participating, is that you would be able to understand the diagnosis and treatment of epilepsy and seizures from a basic point of view, to think about how you would manage seizures and epilepsy during crisis situations, especially when resources are limited, especially resources related to medications and diagnostic resources. So we'll be thinking about that. And then we're going to consider a little bit how war has impacted the care of people with epilepsy in the Ukraine. For these topics, we have a number of excellent presenters. Our first topic is what is epilepsy and why is it important in emergency response? That is going to be presented by Dr. Phillip Pearl, who is the Director of Epilepsy and Clinical Neurophysiology at Boston Children's Hospital and Professor of Neurology at Harvard Medical School. Our second presenter will be discussing diagnosis and treatment of epilepsy with limited resources is Dr. Archana Patel. She is also at Boston Children's and at Harvard University, but she actually does a lot of work in Zambia, and interestingly enough, will be presenting to us today from Zambia. And then our final presentation will be talking about management of epilepsy during war in Ukraine, and it will be presented by Dr. Andriy Dubenko, who is the president of the Ukraine League Against Epilepsy and is a neurologist in Kharkiv, Ukraine. We're going to move through the presentations. We will not have a break between each one, but we will have opportunity for you to ask questions. There's a Q&A button in the Zoom, so if you want to type in questions during the presentations, we will have a Q&A session at the very end. So I'm going to stop sharing my screen, and I'm going to turn things over to Dr. Pearl.
Well, thank you. Thank you, Tim. I also want to welcome everyone from really all over the world for participating in this really important webinar. You know, Dr. Welty is the chair of our task force of the International League Against Epilepsy for emergencies. And we are so happy that we have the head of the International League in Ukraine joining us. I'm going to begin this presentation on the introductory 20-minute talk on what is epilepsy and why it is important in terms of emergency responses. And again, this comes from our emergency task force of the International League Against Epilepsy. Now, epilepsy really is not a disease that you can do a blood test or a CAT scan or an MRI, and sometimes not even an EEG to say someone has epilepsy. Epilepsy is actually an idea, as exemplified by this wonderful history that was just published 2 years ago by Simon Shorvan from University College London. calling epilepsy an idea, and it's a history of epilepsy. Epilepsy is really an increased predisposition to seizures. And what are seizures? You know, the term first came from a military term when they talked about Sparta seizing Athens by Thucydides, the historian from the ancient Greek times. Seizures are electrical storms in the brain that take over or seize the body. And they can be either generalized or focal in onset, meaning coming from the entire brain, or you would say both sides of the cerebral hemispheres, to having a focus. And they can manifest as either motor or non-motor signs and symptoms. Now, the major motor seizure, of course, is the grand mal, the generalized tonic-clonic seizure, meaning stiffening and then jerking. And these are potentially life-threatening and quite dangerous. Sometimes we talk about the minor motor seizure, the current term being the myoclonic seizure for muscle jerk or muscle twitch. And then the absence seizure, or the pedomal is the old term. But in terms of emergencies, we have to talk a minute about status epilepticus, or the state of being in an epileptic seizure. And that is really defined as a seizure or even a cluster of seizures that is prolonged and becomes self-sustained. And the dictionary definition of status epilepticus, or the denotation, is 30 minutes duration from the beginning of the first one to wherever the patient is now. Even if they sort of stop and start and stop and start, it's from the beginning of the first to where it ends. The operational definition of status epilepticus has been shortened to 5 minutes, and we'll talk about why in a moment. Now, status epilepticus is associated with increased mortality or death, severe sequelae in survivors, and definite impairment in quality of life. As far as the causes of status, the most common cause is a patient on daily chronic anti-seizure medication abruptly running out of their medication. And that is going to be a common occurrence in a war-torn setting, or a setting affected by natural disasters, from floods to hurricanes to the wildfires we just had here, and we continue to have here on our West Coast in California. Also, some patients may simply have an exacerbation of their baseline seizure disorder. Now, other triggers that you have to anticipate in emergency crisis settings are sleep deprivation and stress, physical or emotional. Now, when would we use rescue medications? Seizure rescue medications, as opposed to daily anti-seizure medications, are used to stop an emergency seizure that occurs outside of a hospital as soon as possible, whether it's a cluster of seizures, sometimes called acute repetitive seizures, or status epilepticus. And there's also a term called serial seizures, which means a series of seizures. And that is when seizures, as I alluded to earlier, start and stop, without recovery in between. This counts as status epilepticus from the time of onset of the entire series. Of course, rescue medications are not intended to replace daily seizure medications or emergency medical care, but they can prevent a trip to the emergency department or even a call to emergency medical services if families can employ their rescue medications soon enough. Of course, individualized plans should be made ahead of time if possible, but we're here talking about war-torn regions and emergency crisis situations. As far as the definition of status epilepticus by the International League Against Epilepsy, there are actually different stages based on the time course, and these are the labels. If a seizure is less than 5 minutes, it's not status, but it might be considered prodromal or premonitory or incipient status. Once it reaches 5 minutes, it is then a form of status we call impending status. Between 5 and 30 minutes is known as early or transitional status, and 30 minutes is established status epilepticus. If a patient has ongoing seizures after an hour, at an hour, 60 minutes, or if they've received first and second line therapies, traditionally meaning a benzodiazepine and then a follow-up medication like fosphenytoin or levetiracetam or valproate, that would be called refractory status epilepticus. If 24 hours go by, or the patient has already had 1 or 2 continuous infusions of various agents, anesthetic agents like pentobarbital or midazolam propofol, ketamine, even if it's not 24 hours yet, after 1 or 2, we call that super refractory status epilepticus. Now, what is this about 30 minutes? Why is status epilepticus defined as a continuous or a series of seizures or a cluster of seizures lasting 30 minutes duration? Well, mortality shifts. So the overall mortality of seizures is about 2.5% if it's less than 30 minutes. But once it's 30 minutes, it jumps up to 20% mortality at all ages. Now, this is not for febrile seizures. Febrile status epilepticus is not as lethal as non-febrile or epileptic status epilepticus. What happens at 30 minutes? Compensatory mechanisms fail. We'll get into that in a moment. Irreversible nerve damage occurs. Now, we miss a window of opportunity before this, and that's why we've shortened the window to 5 minutes as operational status. So we intervene with rescue at 5 minutes, no longer 30 minutes, which was the case years and years and years ago. Because things happen in that window. What happens? One thing that was discovered is the GABA receptors internalize. Now, this is a little bit of basic science here before I get back into clinical. But here is the synapse. And we have a presynaptic neuron, and here is the membrane of the postsynaptic neuron. And as you may remember, the major neurotransmitters in the brain are GABA, here in green, which is the major inhibitory neurotransmitter, which we need to stop a seizure and to inhibit excitatory signals, and glutamate, here manifests as the NMDA receptor, which is a type of a glutamate or glutamatergic receptor. Now, what happens in status epilepticus is the GABA receptors internalize. It's almost like the cell is recruiting them because they need them more, but we lose them at the cell membrane. And this is the reason why in status, the patient develops resistance to benzodiazepines like diazepam or lorazepam or midazolam. And when we talk about compensatory mechanisms failing, it's because in impending status for the first 30 minutes, our metabolism is compensating pretty well. But what happens at 30 minutes with established status is the seizures start to merge clinically and on the EEG, where you can't tell when they start or when they stop, and the blood pressure starts to go down, and the glucose can't keep up, and the brain damage starts. And at an hour or 60 minutes, refractory status epilepticus, if the seizures continue, they tend to be less kind of flamboyant and more myoclonus or actual electromechanical dissociation, where we may have periodic epileptiform discharges or the EEG ceasing, but the patient can't even manifest a seizure, may just lie there without movement. A very dangerous situation. There are all kinds of things that are happening biochemically and metabolically. There's changes in the chloride accumulation, and the GABA becomes less inhibitory. The receptors internalize, as I mentioned. A chloride transporter starts accumulating the chloride more, and therefore the cell GABA cannot work the way it should. The GABA receptor gets reconfigured. The potassium transporter here sticks the potassium in the cell, which makes it more positive, which is the opposite of what we want. So there are a lot of reasons why, as the seizures go on and on, it's working against the patient. And we know from studies that patients who get delayed benzodiazepines, say after 10 minutes, have a higher risk. So for example, here's a study that was published by our group in JAMA Neurology in 2018, and they looked at over 100 patients who required a continuous infusion for refractory status epilepticus. And it turns out that most of them were getting the initial treatment after 10 minutes. And in addition, of those patients who died, those who got the treatment after 10 minutes, that was a big risk factor for, they didn't all die after status, but of those that did, all of those got the first intervention too late. So it's really important to intervene early for status epilepticus. So the time dimensions for status, remember I said there are different kinds of seizures. For the grand mal or tonic-clonic status, T1 is the time when we say it's operational, it's 5 minutes. T2 is established as 30 minutes. Now, if you have focal status, which means it's a focal seizure. There may be some impairment of consciousness, but it's not a full-blown grand mal status. We use 10 minutes, and we think it takes longer, but it still can lead to brain injury. Absence seizures are different. There, it's not known whether they even cause brain damage. It can go on for hours and hours. But here we use 10 to 15 minutes before we typically intervene with emergency medication. Another danger of seizures is SUDEP. Now, SUDEP is an acronym for sudden unexpected death in epilepsy patients. When observed, and usually it's not, but when observed, this usually occurs in the aftermath of a massive generalized tonic-clonic seizure. And having active generalized tonic-clonic seizures, even 1 or 2 a year, especially nocturnal in sleep, this is the major risk factor for having SUDEP. SUDEP, sudden unexpected death, affects about 1 in 1,000 patients with epilepsy, although many more, 1 in 100 patients who have medically refractory epilepsy, which means at least 2 anti-seizure medications are not controlling the epilepsy. So let's talk about rescue medications so our next speaker can come up. Ideally, rescue medications are effective in small volumes. They can be easily administered by non-medical personnel. They should take effect quickly, and there should be few requirements for monitoring. The fastest method of delivery we have at this time to get these medicines into the bloodstream in someone who doesn't have an IV is through a mucous membrane. And so we use nasal sprays or the nose, mouth, or rectum. There are preparations in development that are transdermal to put patches on the skin, but right now they are just not available. What are the ABCs of emergency management of seizures? Number 1, monitor vital signs, pulse oximetry when you have the equipment for that. Administer oxygen to the actively seizing patient. Check their airway. Ventilation may be needed. Also, if you're an emergency medical personnel, we do want you to establish intravenous access. We do want blood drawn to measure the glucose, a chemistry panel with the electrolytes, anti-seizure medication levels when relevant, toxicology screens, and we do want everyone to be administering seizure rescue medication. Now, the first-line seizure rescue medications are the benzodiazepines, diazepam, which our trade name here in the U.S. is Valium, lorazepam, Ativan, midazolam, Versed. I recognize there are other names in other regions of the world. Now, these can be given intravenously, nasally, buccally, rectally. There are other seizure rescue medications worth having available. Valproate or valproic acid. We tend to call Depakote or Depakine as the trade name here. This can be loaded intravenously, as can levetiracetam, our brand name being Keppra. So a real quick primer for those of you who are paramedics and emergency medical personnel, nursing personnel. The dosing, whether given intravenously or if there's no line, it can be given in the bone intraosseously. Lorazepam, diazepam. Now, lorazepam is typically 0.1 to 0.15 milligram per kilogram per dose. Most people would say the maximum is 5 milligrams. Some hospitals use 4, some places use 10, but it's around 5. Diazepam is 0.2 to 0.3. So see, it's double the dose, or it's half as strong, up to 10 milligrams. I like to use a rule of thumb. When I'm in an emergency setting and don't want to waste time on milligram per kilogram, that should be per kilogram. 1 milligram per year of age works fine for diazepam, up to the 10 milligram total. And for lorazepam, it'd be half of that, up to the 5 milligram total, or maximum. Midazolam is given as the same dose of diazepam, 0.2 milligram per kilogram per dose, and it's often given intranasally. It works fast. It has a very short half-life, so it doesn't last very long. Just like diazepam, the maximum is 10 milligrams, or if you're using a standard 5 milligram, that should be 5 milligram per ml, it would be 1 ml per nostril, because it'd be 5 milligrams in each nostril would be the maximum dose. Now, there are alternate routes of administration. So for intramuscular, midazolam, same dose. Diazepam, same dose, 0.2. Lorazepam, same dose, 0.1 milligram per kilogram per dose, up to 5 milligram. Rectally, diazepam, same dose or even more, up to 0.5 milligram per kilogram per dose. We say up to 20 milligrams as the maximum dose for rectal diazepam. Now, if seizures persist or they recur, we give a second-line agent. The most common would be fosphenytoin, 20 milligram per kilogram as a bolus, maximum 1,500 milligrams. It should be given slowly, between 5 to 10 minutes, I'll say 7 minutes, whether intravenous, intraosseous, or it can be given intramuscularly. Levetiracetam 60 per kilo is a typical loading dose, up to 4,500 milligrams. Valproic acid 40 milligram per kilogram, up to 3 grams as a maximum bolus dose, or phenobarbital 20 milligram per kilogram, but given quite slowly because of the respiratory depression of barbiturates. There are a few other general medical interventions I cannot ignore. If a patient has hypoglycemia, which is another reason to have a seizure, and they're a young child up to 5 kilograms, we'll give D10, W, 0.5 to 1 gram per kilo, or here's the dosage here, 5 to 10 mLs per kilo. If it's more of a school-aged child to an adult, 6 to 50 kilograms, it's D25W. Again, the same dose in terms of gram per kilogram. But the milliliters is a little different. It's 2 to 4 mLs per kilo per dose. And if it's an adult 50 kilogram or higher, it's D50 at 1 to 2 mLs per kilogram. Some patients will seize because of hyponatremia, a severe form of dehydration. They should get 3% sodium chloride, up to 5 mLs per kilogram over 15 minutes. But once the seizure stops, this should be stopped. And other considerations are treat fever and treat hypoxia. So that is the end of this introductory part of the webinar on terms of what is epilepsy, why it's important, and how to handle emergency responses. We're now going to bring on Dr. Patel, who is with us at Boston Children's and Harvard, but speaking to you from Zambia, where she does a tremendous amount of international work and talking, as she's so familiar with, about treatment and diagnosis of epilepsy in limited resource settings. I'll stop sharing.
Okay. So as mentioned, I'm going to be talking about the diagnosis and treatment of epilepsy with limited resources, focusing, of course, on regions affected by crises. So the learning objectives for this talk are to understand the risk factors for increased seizures during humanitarian crises, to define epileptic seizures and epilepsy, to recognize different presentations that epileptic seizures can have, to identify signs that can help distinguish between non-epileptic and epileptic events, and to review the basic management of seizures and epilepsy within available resources. This talk has a broad scope. There's a lot of information here to cover. And so the goal of this is to really give you some resources that will help you in the field as you're managing patients with seizures and epilepsy. So just briefly, I think we all know the global burden and impact of epilepsy, but just to review, over 50 to 70 million people globally are affected, with a prevalence of about 4 to 10 per 1,000. And 80% live in resource restricted regions, where if they are affected by a crisis, or even that effect is compounded, so they're more vulnerable. There's 5 million new cases of epilepsy per year and about 140 deaths attributable to epilepsy per year. Compounding all of this as well is that the average person without epilepsy has about an 8% risk of having a single lifetime seizure. And this risk increases in times of crisis for a variety of reasons, as Phil has already alluded to, and I'm going to go into a little bit more depth on. So why do we care? Why do we think that this is an important topic for humanitarian crises? Well, we know the global burden of epilepsy is high, and we know there's a significant increase in mortality in people with epilepsy. And furthermore, we know that seizure presentations can as much as double during humanitarian crises, as we've seen across the world, including Ukraine, over the last few years. Acutely, the seizures increase for a variety of reasons. The primary one, of course, being that healthcare access as a whole is disrupted. So new diagnoses of epilepsy aren't being made because people are not able to seek out care in a timely fashion. And those who do have epilepsy are often not able to get the treatment they need. And unfortunately, in times of crises, there's a lot of competing priorities. Obviously, there's many issues that you have to deal with in the field, and epilepsy itself is not always prioritized. Unfortunately, this means that there's more seizures existing, there's more deaths to seizure, and the existing stigma around epilepsy worsens. One of the primary reasons of as well is missed medications, as mentioned in the last talk about being a primary cause for status. So access is limited, and as we've seen in Ukraine and other regions, when there is a humanitarian crisis, then the stock of anti-seizure medications can be restricted. They can be hard to get to, and oftentimes if you're exporting the majority of these, that exportation can be limited when there is a crisis occurring in your country, and then you won't have the stock you need. And then there's just simple factors of stress, alcohol and substance abuse increasing, and lack of sleep. So all of these make you more vulnerable to seizures and breakthrough seizures if you have epilepsy, as well as risk of seizures in general. There's also just increased risk of both symptomatic seizures from things like traumatic brain injuries, increased rates of infection and stroke, but these also can increase the risk of epilepsy in the future. So after a crisis, in the years to come, there's going to be an increased rate of seizures occurring and epilepsy occurring as well because of the rate increase of epileptogenic injuries. This is compounded by increased rates of malnutrition, as well as poor prenatal care, which increases the risk of birth injuries, one of the most common causes of acquired pediatric epilepsy. So we already heard what a seizure is. Just to review, a seizure is, any transient or paroxysmal event, but an epileptic seizure is a transient occurrence of signs and symptoms specifically due to this abnormal or excessive synchronous neuronal activity in the brain. And again, as mentioned in the last talk, very simply thinking about this, it's a balance of inhibition and excitation. There are, of course, many neurotransmitters involved, but the primary ones driving it are going to be glutamate, which is excitatory, and GABA, which is inhibitory. And when you're having a seizure, you have an imbalance of increased excitation and decreased inhibition. And as you heard in the last talk, this is essential for understanding how the anti-seizure medications are working. So what is epilepsy? Epilepsy is the ongoing tendency for unprovoked seizures. So we define this pretty specifically in that 2 or more unprovoked epileptic seizures separated by at least 24 hours meets the criteria, because that tells us that there is a high risk, greater than 60%, that you're going to have another one. But we also know that you can make the diagnosis by saying that someone has 1 unprovoked epileptic seizure, plus your judgment that there's a similar recurrence risk as having a second one already. And this is really important if you're working in the field and you have a patient population that's relatively transient, because you may not have the capacity to wait to see if a second event is going to occur. And it should be determined by clinical judgment. This can be an abnormal EEG. It can be a suspected epilepsy syndrome, a strong family history, a known brain malformation, if they have an abnormal neurologic exam showing you that they've had some sort of brain injury in the past, etc. I think one of the most important things to understand about epilepsy, though, is that it is a very heterogeneous condition. It can occur from people who are completely healthy to individuals who have a host of other neurologic problems. It can occur 6 months after you've had a potentially epileptogenic insult, like a traumatic brain injury, to years later. And it can go from being well controlled to having poor control within months to weeks. So it really is a variable condition, which makes it very hard for people with epilepsy to deal with, and it also makes it very vulnerable to times of stress. So how do you recognize epilepsy? So I'm going to try to make this as simple as possible. So we're going to just go through a few basic ways to think about how to frame understanding if you have someone with epilepsy in front of you. So rule number 1 is that epilepsy, like we've said, is defined by recurrent unprovoked seizures. Rule number 2 is that not all seizures are generalized. 3 is that seizures tend to be stereotyped and rhythmic and follow brain physiology. 4, people can have both epileptic and non-epileptic events. And 5 is that your history and physical exam are your best clues for diagnosis. Diagnostics are supportive. So let's break this down a little bit more. So as stated, the definition of epilepsy is recurrent unprovoked seizures. So if you have someone who's having provoked or acute symptomatic seizures, this is a different situation. So an acute or transient problem affecting the brain, such as a head trauma or a brain infection, should be focused on treatment for that underlying condition. Now, of course, you're going to treat the seizures that you see with the emergency management that was just reviewed by in our last talk, but you also want to be addressing the underlying condition. And this is not a person who at this point meets the criteria for epilepsy, although they are now at increased risk. Unprovoked seizures are caused by the base state of the brain. So this can sometimes be a little bit confusing because someone with an old stroke, this is now how their brain is, and that can be the cause of their seizures, but it's not acute, it's not a new stroke. And so this can be someone who's healthy or someone who's had a prior brain injury in the past. The second rule of thumb is that not all seizures are generalized convulsions. These are, of course, the easiest to recognize and the ones that are the most concerning and kind of draw your attention for treatment. But focal seizures are also really important to recognize and to be aware of. So generalized seizures very simply just involve the whole electrical circuit at once, and focal seizures are originating from one specific part of the brain, and they can spread to they can either stay focal, they can spread a little bit regionally, or they can spread to the whole brain and be secondarily generalized. It's the beginning of the seizure that's really essential to capture. And so when you're taking a history, trying to understand how a seizure starts is really important because that's going to help you classify something as focal or generalized. And this is essential because it helps you know what diagnostic testing you really need to get and what medications to use. Next rule is that seizures tend to be stereotyped and rhythmic and follow brain physiology. So again, a seizure can occur in any part of the brain, and they can be a variety of symptoms. So we think of generalized convulsions, or you may even think of like one side of the body jerking away and that being a seizure, and of course those are. But seizures can also be as subtle as visual disturbances or a sense of nausea followed by motor movements, auditory disturbances, anything your brain can do essentially. But what they shouldn't be is not make sense physiologically. So you shouldn't have your right arm shaking and then your left leg shaking at the same time, because that would be pretty unusual. It would mean that you have two separate epileptogenic foci. Usually you're going to see a focal seizure spreading along the motor homunculus. And again, it's important to isolate this because it really helps you make that diagnosis and really understand what you should be doing next in terms of medication and diagnostics. So the fourth rule is that people can have both non-epileptic and epileptic events. Now, this is complicated. When you're trying to make a diagnosis to assess if someone has epilepsy or not, the first thing you want to know is, are their events actually epileptic? And there are many things that can mimic seizures. They range from tics to fainting to movement disorders. But one of the most concerning ones, particularly in times of stress, are psychogenic non-epileptic seizures. Psychogenic non-epileptic seizures, or PNES, can often coexist with epileptic events. So you certainly can have PNES and not have epilepsy, but you also can have epilepsy. So you want to be careful in making a judgment that if someone has one type that they can't have the other. Usually, with careful history and time, you can identify stressors and psychiatric comorbidities, but not always. And oftentimes there is concomitant neurologic disease. Headaches are most common, but as noted, epilepsy can be there as well. Now, general rules of thumb are kind of here in this table. These are general and not always what people will follow. But overall, for most seizures, most epileptic seizures are going to abort spontaneously within 3 to 5 minutes at most, usually less than 3 minutes. Psychogenic non-epileptic seizures often are prolonged. They are often very dramatic. They will have motor findings such as pelvic thrusting. They will not follow that physiologic pattern often that I mentioned. They can have kind of this long kind of onset and offset in comparison to epileptic events, which typically will have kind of an abrupt on and off. And the PNES events often are more complex and dramatic. Now, just by nature of what type of event it is, it's going to be occurring in wakefulness. This is not to say that someone is faking it, but the way that the mechanism works is that it's going to happen out of wakefulness versus epileptic events can happen in wakefulness or sleep. And it's important to recognize that oftentimes if you take a careful history, you should be able to pinpoint a trigger for the PNES events. Incontinence is not a diagnostic guarantee because while it's more common in epileptic events, you can see it on PNES as well. So all of this is kind of leading towards how do you make the diagnosis of epilepsy? And this is where we talk about the fact that history and physical are really your best clues, which is why I'm reviewing, some of these aspects that you want to pay attention to. Obtaining that seizure description is essential. The onset is key. Is there any focality? Was the patient aware? Did they have any prodromic symptoms? Was one part of the body involved or the whole body? And, you know, the best way to do this in the most efficient way that I have found is just to act it out, just to show them different options of what a seizure can look like. If you have the option, see if they have any videos and, you know, if they can get any. You also want to know when was it first seen? How many have they had since? The length of the events, the frequency, associated features. Do they all sound similar? Are they stereotyped? Can they be provoked? Any tongue biting, incontinence? Are there any triggering or provoking factors such as, you know, missed medications, infections, sleep, etc.? And any risk factors, any family history, any past medical history of some kind of brain insult, any neurologic findings on exam. And then we try to take that information and classify the seizure type that you have. And this is the ILAE classification system where we talk, again, broad categories are focal, generalized, mixed, or unknown. And then you kind of break it down further, as you can see here. And then the ILAE has expanded this even further for more detailed seizure types where you can talk about, again, on focal onset aware or impaired awareness, and then the variety of motor and non-motor events that you can have, and for each of the different types. So again, this is quite a bit of information, but ILAE actually has a checklist that can help you go through these seizure types with simple instructions, and is very helpful for you taking your history in an efficient manner. And that brings us to then, what diagnostics do you need? So of course we think about EEG because we think that's a diagnostic test for epilepsy. But EEG really is only providing information of your risk of having a seizure, and it's pretty imperfect in that. So if it's positive, if it's showing you some epileptiform activity, then it helps support your diagnosis. But if it's negative, the sensitivity is between 30 to 60%. So it's not very helpful. And when I'm talking about EEG here, I'm talking about a routine awake and sleep study that's about 40 to 60 minutes long, which is typically what we get unless you're in a center that can do longer studies, which requires quite a few more resources. EEG can help if you've only had one unprovoked event and you are in a place where you can get EEG, but you can't, you know, make the diagnosis otherwise. So that sometimes can be very supportive and helpful. It can also help if you're unsure of the diagnosis, but you really want to know what's your level of uncertainty. So if you have a strong suspicion clinically, an EEG is not really going to help you. A normal study is not going to rule out your diagnosis, and an abnormal one is just going to confirm what you've already decided. If you have a low suspicion, a normal EEG could potentially support it, but people can have abnormalities on their EEG and not have epilepsy. So you can confuse the picture if you're pretty convinced that what you're dealing with are not epileptic events. But if you have moderate suspicion, this is where an EEG may be helpful because you're uncertain of which way to go. It also can be helpful if you're concerned about subtle or silent seizures, or if you're worried about poor response to anti-seizure medications and whether or not you have the right diagnosis. In terms of neuroimaging, it is recommended in general if it's possible. So whenever you have a new diagnosis of epilepsy, if you have the capacity to get neuroimaging, you certainly want to try. But if you have to triage who gets it, you really want to focus on those who have focal findings. So either focal semiology or seizure type, or focal EEG findings. You also should be considering it if they're not responding to anti-seizure medications or have unexplained cognitive impairments. And overall, when you're thinking about what imaging to get, you want to try for MRI because it's better in terms of resolution and lack of radiation. But a CT certainly is going to be sufficient to rule out the big things that you're worried about. So in places where you have limited resources and CT is all you have, you really do want to use that for people who are presenting with focal epilepsy or seizures. And just to support this point further, there have been studies done in pediatric epilepsy, at least, that have shown that while imaging can be helpful in identifying the etiology in focal epilepsies in about a third of the cases, it really doesn't alter initial management at all much. It's altering it less than 10% of the time, and really is more relevant when you're in more complex management considerations like epilepsy surgery. So in terms of treatment of epilepsy, the key points are to first identify the seizure type so you can start thinking about what type of medication to use, determine if diagnostics are needed, and then assess what medications are available in your region and what current access issues you may be facing. You then want to think about the individual profile, age, medical issues such as any renal problems, the type of seizure, side effects that you have to be considering, and then you have to think about special populations such as women of childbearing age, people with HIV, etc. And you want to think about again, accessibility. Can they actually get the medication? So this is the WHO essential medication list for anti-seizure medications as of 2023. I think, in many regions you have more medications than this, but these are the ones that are listed on the EML to be aware of. It's a pretty complex picture to think about how to make that initial management decision. So I'm just going to give you some general guidelines and then some resources that you can use to pick the right medication to start with for your individual patients. So first of all, we talked a lot about focal versus generalized epilepsy, and that's because that really does influence the medication you pick. So carbamazepine is avoided in generalized epilepsy as it can be unhelpful, and in some cases, particularly childhood epilepsy syndromes, make the epilepsy worse. Carbamazepine, as well as oxcarbazepine and lacosamide, however, are excellent options for focal onset epilepsy and often most effective for that. So you want to be able to distinguish which one they should use it for. Levetiracetam is often the preferred starting medication for the simple reason that it is fairly easy to start in patients of all ages. It helps for both focal and generalized epilepsies, and it really doesn't require much blood monitoring and is overall well tolerated. However, caution should be made for anyone who has any renal disease, particularly in the elderly, and you also want to consider any underlying psychiatric disorders that can be exacerbated by the use of levetiracetam. Valproic acid should be avoided in women of childbearing age and in children under the age of 2. Phenobarbital is an excellent and effective medication, but it certainly isn't the preferred one if you have alternative options due to the fact that it can cause more sedation and impact development. Phenytoin has even more undesirable side effects, so it's usually kind of the bottom of the list unless it's all you have. And of course, if that's all you have, then you want to pick a medication you can administer. It's helpful to be able to try to tailor medications for specific seizure types and epilepsy syndromes, but if all you can do is divide into focal or generalized epilepsy, you're still in a good place for starting medicine. And then the final consideration you want to have is in pediatrics. I'm a pediatric epileptologist. The formulation option should be considered. For children, we dose medication by weight. And so if you have the wrong formulation, it can be very hard to administer the medication. I have been to many clinics out here where the only anti-seizure medication available is a 100 milligram tablet of phenobarbital. Phenobarbital tablets are quite small, and it is near impossible to even quarter that to be in anywhere in a safe zone dose for a young child. So this is a graph that we developed through the Lancet Commission on Epilepsy. That's it's in process for publication, but it was shared with me with Jackie French, who came out of our Lancet Commission where a bunch of us epileptologists had put together our preferences for anti-seizure medications for the different types of epilepsy listed on top. And the goal of this is to give you kind of a general outline on how to pick the first medication that would be preferred. So, for example, if you have generalized epilepsy, then we know that these green boxes are the ones that people think are the most common to be used and the best options for a first-line treatment. So you would want to either, if it's a male and or a female who's not of childbearing potential, then you could consider sodium valproate. Otherwise, levetiracetam or lamotrigine would be excellent options. Another resource that you can use is the EpiPick application, which is available online. And this is a really great way to just put in your patient characteristics, and then you can see what medication options would be the best ones to pick for that patient. In terms of starting the medication, your general rules are going to start low and go slow. So you're going to titrate weekly over a 2 to 4 week period in most cases. Lamotrigine is a different story. That one goes much slower, so often not the preferred one if you're in an emergency situation. You want to assess routinely for adverse reactions and provide information to the patients on what to monitor for, and assess treatment response by impact on frequency and severity of seizures. So assessing the treatment, your basic principles are the seizures improving in control? How is the medication adherence? And are there any side effects? If you get a partial response to the seizure frequency, then you want to optimize the medication you're on. If there is no response and you're at a therapeutic dose, then you might want to consider switching to another medication instead of just working with the one that seems to be ineffective, and you would cross titrate with coverage. If you're on the maximum dose of your first medication, but you still haven't achieved perfect control, but you have gotten some, then you might want to add a second medication. And you want to really balance your quality of life and seizure control with these medication adjustments. Now, one of the issues that comes up a lot of times in crises are, what do you do if someone's on a medication that's now unavailable? So obviously, we really try not to switch medications in people who have controlled epilepsy when they're on a good regimen, but it can be unavoidable at points. And so there are resources that exist on the ILAE website. This was also put up at the beginning of the webinar, which can give you directions on what to do in those instances. There's quite a bit of data in this, so we don't have time to review it in depth today, but I do want to ensure that all of you pay attention to this resource because it's very helpful. And then we heard a lot about status epilepticus in the last talk and how to manage that. But in terms of any seizures, and particularly in the field, you want to be prepared to administer seizure first aid, even if you have nothing else around you. And so if you find someone who is seizing, you want to assume that they're in status epilepticus and treat it as such. But anyone who's having a seizure, you want to immediately put them on their side, and their head should be turned to help them breathing. Do not put anything in their mouth or restrain the person, and stay with them until they wake up. Again, as you heard in the last talk, if you're going to treat at 5 minutes, or if you found them down because you don't know when it started. If you have any concern, you're going to be treating anyways to stop the event. So just to briefly review, in terms of diagnosing epilepsy, your history is key. And the elements of that is to remember that you should be investigating for recurrent, unprovoked epileptic events. Not all seizures are going to be generalized, so keep in mind what type of seizure it may be and get a good description of that seizure. Remember that seizures tend to be stereotyped and rhythmic and follow brain physiology. People can have both non-epileptic and epileptic events, and your history and physical exam are going to be your best clues. So if you can't access diagnostics, you can still diagnose and treat epilepsy. You want to, in terms of treatment, you want to assess what medications are available, so be familiar with that. Be comfortable with seizure first aid and use existing resources to supplement gaps in anti-seizure medication availability. You also want to remember that this is a very devastating condition, and it's even more stressful in times of crises, so to provide psychosocial support as much as you can. So again, just a few take-home points. Presentations of seizure and epilepsy can increase significantly during times of crises, as can psychogenic non-epileptic events. And it's really important to try to distinguish between the two. It's essential that we do prioritize care for people with epilepsy, as there's a high risk of mortality and morbidity associated with seizures and disruption of care in times of crisis. And all healthcare providers should recognize basic signs of seizures and basic management strategies. Thank you. I'm going to hand it over now to Dr. Dubenko.
You know that in 2014, Russian Federation started this dangerous war, and full-scale invasion started 3 years ago, even 3 years ago. So we have such an experience. You can see our territory, which was occupied, which was deoccupied, and another part, you can see our territory in which we have dangerous fighting with the Russian Federation. So, about the beginning of this war, our doctors had a lot of problem in war, around of war zone. It was destruction, closure, termination of suspension of medical facility, of diagnostic center, laboratory center. So we have stoppage of pharmacy network. For example, in Kharkiv, my native city, we had, I don't remember, or 13 or 14 pharmacy stores in the beginning of March 2022. So it's in 1.5 million city. The danger, of course, associated with shelling both for doctors and patients, stopping or complication urban, suburban public transport, of course, general dangers, and so on. Another problem had doctors in the beginning of this war in the areas removed from the hostilities. At first, it was sharp increase of number of patients in general, of course, including a patient with epilepsy in small towns, in villages, because the majority of people from east of Ukraine try to leave this part of Ukraine and traveled to west part. Of course, it was impossible to leave to find apartment in the big cities in west part of Ukraine, so majority lives in small towns and villages. Of course, it was a significant increase in the burden of healthcare system, reduction of range and quantity of medicine in the pharmacy network, because nobody could understand, could think about possibility to decrease quantity of people in 3 or 5 times. Lack of previous medical documentation, laboratory result of temporary displaced, including epilepsy patients. So patients have no documentation, patients have no diagnosis, have no previous EEG, and of course it was very difficult for doctors to understand what this patient had, how medication this patient had before. And of course, additional psychiatric comorbidity and polymorbidity, it is the result of the war. Now it's about doctors. Now about migration of population of Ukraine as a result of this war. In 2021, population of Ukraine was near 41 million of people. So May 2023 United Nations data, more than 8 millions of Ukrainian lived aboard of Ukraine in, and 5 millions, more than 5 millions was registered for temporary protection or similar schemes in European country. Last update is December 2024. Refugees from Ukraine to Europe and have some registration as temporary protection or something look like this was more than 6 million and near 7 million patients in all countries of the world. So now 2 million Ukrainians cross the border with Russian Federation or Republic of Belarus. Some of them return to Ukraine through a European country. Some of them live in Russia, and about some of them we have no information. Except this, we have near 5 million people which was internally displaced person in Ukraine, so they left their homes and try to find more safety place in Ukraine, and of course they have significant social, medical, healthcare problem. So the greatness of this problem, thus 10 or 15 million Ukraine were forced to leave their homes and change their place of residence. So we remember that 41 million was in Ukraine, were it in Ukraine in 2021. So, and this process is ongoing. And now about epilepsy patients. Of course, we have no statistical data of the number of people with certain diseases which receive temporary shelter in other country. Now, taking it into account the average of pre-war statistical indicator and understanding that mostly people with a disability, women with children, and men who can't took part in fighting in this war, usually left Ukraine. Number of people with epilepsy, according our calculation, was something from 51,000 to 83,000 adults and children with epilepsy, which lived Ukraine and went to another country, and near 15,000 of people with epilepsy became internally displaced persons, so they have a lot of social and medical problem too. The main problem of our patient, of course, it's destruction, closure, cessation of medical facility, of laboratory center, and so on. Of course, it's stopping pharmacy network, dangerous associating with shelling, stopping or complication the operation of our turban or some turban transport, and so on. Which doctor have too, but specific problem for patient. It's lots of medical documentation, laboratory results at first, and loss of contact with usual healthcare unit. It's impossible to found a new one. It's impossibility, of course, to take an anti-seizure regime acceptable for patient. And of course, a psychiatric comorbidity. Patient who went abroad generally had the same problem, but have additional problem. Of course, it's not understanding the different status when entering into another country. Now, it's very pity, but now majority of Ukrainians know all statuses in a lot of countries. Poor knowledge of lack knowledge of language. Very small part of patients speak English or some another foreign language, not understanding the healthcare system in another country. Patient leave the Ukraine, patient try to find some doctors in another country, but they usually did not know how to do it. And of course, lack of information about epilepsy treatment center. So it's about the destroying of our Ukrainian healthcare system. was verified more than 2,000 attacks to health care units. As a result, 200 deaths and nearby 700 injuries of health worker and patient in healthcare unit. According to the latest data, more than 800 was fully or partly destroyed. Of course, we try to rebuild our medical care system, but it's dangerous. But attacks on, for example, in November, more than 180 drones were launched, impacted 17 regions. So destroying of our medical care system continue. It's photos, it's Mariupol, Kherson, Kharkiv, and Mykolaiv. So now about what can we try to do Ukrainian League Against Epilepsy. Of course, we all understand that public organization definitely cannot replace medical care system. In peacetime or in wartime, but can't. But we should something to do, and why? Because we understood that epilepsy cannot be priority in wartime. We considered it necessary to do everything possible for supporting our epilepsy patient. We understood that first of all we need anti-seizure medication, because I describe our catastrophic situation at the beginning of the war. So we ask humanitarian aid to all possible foreign and domestic authorities. Many people expressed a desire to help, but neither we nor our patient had no experience, have experience how to do it, have no experience in such logistic. So Ukrainian League Against Epilepsy, at first we created separate section of our website, ILAE during the war, for all the useful information for our doctors and for our patient. We understand that a lot of doctors which have not experienced in past now need to treat epilepsy patient. More, we understand that a lot of epilepsy patient lost their usual healthcare unit. So we started online consultation. We provided 2 groups, pediatric specialist and adult specialist epileptologist. We have done call center for patient common for all Ukraine, and its work, it's continued, was continued working even after the death of employers of this center. We collected information about medical centers in different countries and provided it to our website, and try to contact with our foreign colleagues for understanding and for understanding health care system for epilepsy patient, and the material relate about situation is Ukraine. We and our ask about the help. We publicate in a big journal. It was Epigraph, Lancet, Seizure, so on. This is our publication. It's about our call center. Very pity history. Our call center was organized in Vinnytsia Medical Center near Med, which was destroyed by Russian bombing. You can see it on this photo, but they did not stop their work despite this situation. It's our website. It's my friend, my colleague, which was killed, Pavlo Kovalchuk, which made the table, the Google table for getting anti-seizure medication need for patient, and he was killed by Russian bombing in Vinnytsia. He worked in that medical center near Med. Now, International League Against Epilepsy, as soon as we recovered from our first shock, we had a good contact with, was established with ILAE to support the main direction. Of course, it's in first humanitarian anti-seizure medication aid, brief recommendation for patients which lived Ukraine due to the war, and this was translated into Ukrainian, a lot of advices of people in crisis situation. Treatment strategy, Archana said about this in people with epilepsy during time of shortage anti-seizure medication. Which was done very, very quickly and was very useful for a Ukrainian doctor in the beginning of the war. Later, International League Against Epilepsy took an active part in providing Ukrainian clinics with modern AEG machine. Ukrainian had free access for Congress, which ILAE was organized and in last year too. So a survey on mental health in patients with epilepsy was done, and we have very interesting result. And of course, ILAE emergency response task force group regularly discussed and they continue to discuss the most actual issues of our problem. So mental health and quality of life about for patients with epilepsy in Ukraine. It's adult patient now. We are finishing such information about pediatric patients, so we can see that 52% have seizures worsening, and we can see that 42 patients which have well-controlled epilepsy had worsened too. Difficulty with anti-seizure medication 20 and difficulties accessing healthcare 25%, difficulty anti-seizure medication 34%, and the very big percent about psychiatric comorbidities, 46 psychological stress, 60 for anxiety, 50 depressed, and so on. So we can see that it's very significant data, significant increases of epilepsy worsening, and significant such psychiatric comorbidities as anxiety and depression. Not only International League Against Epilepsy, a lot of another public organization helped us in the beginning of the war. Of course, at first, Poland Foundacja Emerging, we organized a lot of travels, a lot of anti-seizure medication, but about this later, Brother and Brother Foundation, Razom from Ukraine, TeleEG Foundation, and so on. You see, I can't said about all organization because a majority of members of Ukrainian League Against Epilepsy do this humanitarian activity, and now we can we don't know all list of our helpers, but it's very, very big. It's about emerging foundation. So from February 26, so 2 days after war, in Warsaw and in Lviv, we organized 2 hubs for anti-seizure medication from all countries. This anti-seizure medication came to Warsaw, then were packed and went to Lviv, and then to Kiev, and from Lviv and Kiev to another region of Ukraine. It's the beginning of the war. Now, what we have now? The war continues, migration continues, destruction in peaceful city continues, including destruction of medical facility. Nevertheless, many medical facilities resume their work even in area where close to front line. The situation with basic anti-seizure medication has improved significantly. Diagnostic capability have been largely restored, except for occupied and nearby frontline territory, e.g., MRI, basic laboratory test, we can do in majority part of Ukraine, but not in occupied part in Ukraine. The possibility of surgical treatment of epilepsy are being restored. Also, there will have not yet reached the level that were before COVID-19. The problem with anti-seizure medication supply still remain critical in occupied zone. Really, we don't know what all situation in occupied zone, but our people which try and had possibility to return to Ukraine from occupied zone describe very dangerous situation. But say once more that we really don't know the situation. My problem remained with medication for emergency care and treatment status epilepticus, and as well for treatment of severe early childhood epilepsy. There have been many veterans who have developed symptomatic epilepsy after severe brain injuries, and the quantity of such veterans with symptomatic epilepsy will be more and more. It's very pity, but I really know a lot of such patients. The number of Ukrainian, of course, including patients with epilepsy who need psychological and psychiatric help, in constantly growing. The severity and relevance of main problem that excited at the beginning of the war are gradually decreasing. But new, often unexpected problems are emerging, which can only be truly assessed after some time. So our terrible experience. Of course, unfortunately, we have experienced situations that one would never wish to anyone. It's dangerous, real dangerous. But there are experience, and we need it. This experience need to be analyzed. No, of course, public organization cannot take over the function of healthcare system, but can do something useful for cohort of patients with whose care the public organization is involved. It's necessary to clearly understand that helping patients in crisis situation required a systematic approach and cold mind. It's very difficult, but we need cold mind for this. It's will necessary to solve problem and did not even have any idea of before. The greatest effort should be made to inform patient. It's very important for patient to be informed about the possibility of receiving medical care, providing chronic patient with vitally necessary medicine, anti-seizure medication for our patient. Efforts to remotely consult other doctors by epileptologists to ensure adequate medical care for patient during the migration and also responsible. That's the reality of modern world. It's very pity, but it's reality. The constant threat from aggressor country, even in the continent of Europe, and the experience of Ukraine during the full-scale war was provide the need to develop guidelines for the treatment and monitoring epilepsy patient. No, not only epilepsy patients, but I am president of League Against Epilepsy. During hostility in global disasters, we suggest creating working group to develop guidelines for low-income country and for a country with high economic development, possible separately for individual group of country by geographic region. The war of Ukraine unfortunately showed that healthcare system, even in developing country, are not ready to overcome global disasters. Something so, thank you for your attention.
Okay, thank you, Dr. Dubenko. And unfortunately, Dr. Pearl had to leave to for another very important meeting. He had to join, but we still have Dr. Patel and Dr. Dubenko. And we have a few questions. And if you have more questions from the participants, please enter them into the Q&A tab at the bottom of your Zoom meeting. But I want to start out because it's come up a couple of times, just to highlight a little bit about what the ILAE has done related to emergency crisis response. ILAE is a professional organization, so in some ways we're limited in what can be done. Educational programs like this are one of the things that we can easily do and provide. But what we have done is we have worked closely with the WHO and the health clusters to raise awareness of epilepsy. We've also been very involved in addressing the essential medication list, as well as the emergency health kit. So at a global level, being involved with that. We've also been involved with the health cluster in Ukraine, as well as internationally with the health cluster. Anyway, that highlights the ILAE process and what we have been trying to do along with the resources on the website. So one question I think was really interesting toward the beginning, and Dr. Patel and Dr. Dubenko, I think, can answer this question, is the use of smartphone apps, especially during crises. and how they might be used during crises to
About smartphone, of course, it can be useful. It can be useful for do video. It can be useful for read the information from ILAE or ULAE site. More, it can be useful for send video for epilepsy for a doctor which which epilepsy consultant doctor something so Archana,
Good.
maybe you want to add something.
Yeah, no, I fully agree. I think you know, we've done research on this as well. It's an excellent triaging tool. I think all of us that clinically practice always love it when someone comes with a video because it's very helpful to us to make a diagnosis. Again, you know, one of the hardest things in the field, particularly if this isn't your area of expertise, or even if it is knowing, is it an epileptic event or not? Because that's obviously the linchpin of kind of moving forward on treatment. And so having a video can really help you. And so if it's feasible, certainly. And then, you know, yeah, I also agree. The goal of this isn't to say that when you're the healthcare provider in the field, you have to be able to do all of this alone. So a video is a really great way to be able to connect remotely with a specialist and say, I have a patient who has this event. Is this epilepsy? And what should I do with it? What should I treat it with? So it can be helpful in many ways when it's available. It just always isn't available.
Okay, very good. Thank you for that. Another question that came from the audience or the participants kind of revolved around the question of handling special populations, and in particular women with epilepsy during a crisis situation, knowing some of the concerns and limitations that may be available with medication. So I think if both of you would want to comment on handling special patient populations and especially women with epilepsy who may be in emergency situations. So Dr. Patel, go ahead, and then we'll have Dr. Dubenko.
Yeah, you know, special populations in epilepsy are always tricky, particularly when you're working with limited resources or in a setting of crises. Women with epilepsy, particularly if they are pregnant, there's a lot of considerations to be made. Certain anti-seizure medications significantly change in your blood level during pregnancy. And so, for example, lamotrigine. And so it has to be monitored carefully. And that may just not be practical when you're in an emergency situation. And so in these cases, I think, you know, for this particular special population, as well as other ones when you're uncertain, this is where you really want to reach out to the network of consultants that can help guide you. Again, remote consultation is an extremely valuable tool, and these are the cases in which it would be helpful for you. What we do know is that out of the most commonly available anti-seizure medications, levetiracetam is going to be safe to use in most of these special populations, including women with epilepsy, people living with HIV, et cetera. So I think that's probably your safest one to use. And fortunately, it's becoming more accessible.
Dr. Dubenko, do you have any added comments?
Yeah, at first, such patient need to be consulted by epileptologist early as possible for understanding their problem. It's the first position. Second, if it a young woman, if it girl, more teenager woman, all doctors must think about possibility of that child burden. It even in 10 years, 12 years, if a doctor, a pediatric neurologist have some doubts, such girl need to be consulted by epileptologist for changing anti-seizure medication, because it's really very difficult to change scheme of anti-seizure medication in 20 years, that especially is in severity duration if it good scheme and patient have control of seizure. About the other specific patient about the same situation, patient to be need to epileptologist consultation early. It is possible because rather often we consult our patient where it's too late to change something.
Yep, very good. Thank you, Dr. Dubenko. One last question for Dr. Patel, and then we have a couple of wrap-up items. The possibility of seizures in normal patients, and what to do about that, how to think about seizures in a patient that is otherwise healthy.
Yeah, if it's that's something we should all realize. So that's why, the definition for epilepsy is showing a tendency for recurrent seizures because of the fact that all of us have a risk to have a single unprovoked seizure. We all kind of get a pass on that one, and it doesn't mean that you have epilepsy. And so you don't want to be starting anti-seizure medications in those patients unless you can establish that there is a risk for further events. And so that's where the history really comes into play. This is where an EEG can be helpful, as I mentioned. But it's just a simple fact that, you can have an epileptic event and not necessarily have further ones. If you are, the tricky part is that when we're in a stable situation, a stable environment, we can sometimes put enough give rescue medications to the patient, plan for follow-up, systematically do diagnostics, and have the time to see their risk for future events and start anti-seizure medications when appropriate. When you're in a time of crises and you have a transient population, you may have to make a hard decision of saying, I think your risk is sufficient, or I'm not. I think your risk of having further seizures is worrisome enough that you need to just start medication right now, and then we'll reevaluate this when there's a better time of stability. And that may be a decision you have to make.
I absolutely agree.
Yeah, well, good. Well, I think we're going to wrap up this webinar. I will make one other comment at the end. No matter if it's during emergency response or just in a stable situation in dealing with people with epilepsy, it really takes a team. And there are a lot of different individuals, not just physicians, but you have nurses, pharmacists, psychologists, therapists, psychiatrists, psychologists, everybody involved in caring for the patient with epilepsy. And it becomes, I think, more critical to engage with them during emergency responses, because many of those specialty areas can help in designing unique responses to what is being faced, because every crisis, every emergency is different. And I want to thank all of you for taking the time to join this very timely and important topic related to epilepsy. And we appreciate all of you, and look forward to providing more events like this for each of you. Thank you, everyone, and you have a good evening. I think most of you are in Europe, so it will be evening there. So you have a good evening. For others in other parts of the world, a good rest of your day. Thank you for joining us.